Thanks for joining me. I'm going to spend the next half an hour or so talking about ECG interpretation with a particular emphasis on ECGs that convey a risk of bradyarrhythmia. Hopefully in that time you'll move from a state of furious anger and frustration when faced with an ECG screwed up in your fist to a state of Zen-like transcendence where an ECG is very much your friend. I'm assuming some basic knowledge about the ECG and how to go about interpreting ECGs. So this is our first ECG. I'm sure you run through a series of things in your mind when you check a new ECG, like the date it's been taken, like the patient information, check it's all correct. And then you move on to look at the atrial activity, followed by the QRS duration and axis, and then look for interpretation of specific features. So looking at this ECG, what is the abnormality? And I hope that you're immediately drawn to the long PR interval here. What is a normal PR interval? Well, it does depend a little bit on the heart rate. This is a relatively bradycardic ECG, so you might allow for a longer PR interval of around 200 milliseconds. If this were a tachycardic ECG, 200 milliseconds would be on the long side. But broadly speaking, this is the range you're looking at, which each small square being 40 milliseconds, that's around 3 to 5 small squares. Here we're measuring around 7 small squares. So this is first degree heart block. And in itself, it's not necessarily of concern. You might want to think about investigating the patient for more bradyarrhythmias, but only if there were symptoms pointing in that direction. In isolation, this doesn't really need any further consideration. But there are different types of first degree heart block, or different degrees, and this is, I apologise for the fairly poor quality ECG, but this shows more pronounced first degree heart block that might make you think a bit harder and might make you want to investigate it, even though all the guidelines and textbooks would say first degree heart block doesn't require a pacemaker. I would be wanting to investigate this further. And in fact, this patient had an aortic root abscess, and this was their ECG a day or two later, as the PR interval has profoundly prolonged. And this is the kind of ECG that makes you very concerned that the patient's going to develop complete heart block. Now we'll look at this ECG. I'll give you a moment to just think about it. So if we look in V1, we can see that the QRS duration is prolonged. And if we look at V1 and V6, we can try and decide, is this right or left bundle branch block? The best way of telling that, there are lots of different ways, is to, as I say, look at V1 and V6, and marrow is the most classic mnemonic for remembering this. We're looking at an RSR pattern in V1, which looks a bit like an M, and importantly, for it to be typical right bundle branch block, the first R should be lowercase little, followed by a big uppercase R. So small r, big R, RSR pattern. That is characteristic of typical right bundle branch block. If the R waves are reversed in size, that would be atypical, and that would suggest a rhythm originating in the ventricle rather than being conducted through the bundles. The other feature is the W here, which I'm not so convinced by. You can say little Q wave, R wave, S wave, W, but I would be more saying there's an S wave here. So I tend to think of M. Yes, I certainly agree with that, but I think of S and Morris here. So right bundle branch block. What about this ECG? So again, we have a broad QRS, and again we have an M with a small r, big R, RSR pattern in V1, and here we've got a deep S wave in V6, so we have typical right bundle branch block. Another way of remembering right versus left bundle branch block, if you want to make it very simple, is that there's predominantly R wave in V1. Predominantly R wave in V1, R for right, right bundle branch block. If it's predominantly negative, then it's left bundle branch block because it doesn't begin with R if it's an S or a Q wave. So predominantly positive right bundle branch block. It's better if you can remember the morphology, the typical appearances, because that can help you decide if it's supraventricular or if it's ventricular in origin. And then look at the axis of this ECG. Now, if we put up an axis diagram, we can see that AVF is straight down at the patient's feet. We've got leads 2 and 3, which are slightly to either side of it. I like to remember AVR and AVL by just lifting my arms up in the air, and the AVL is looking along my left arm, AVR looking along my right arm. You can see that AVR is looking at the heart from the top and in the opposite direction from the normal passage of the electrical signal from the right atriums through to the ventricle. And so AVR is almost always inverted, and for it to be positive, we would be looking at the rhythm originating in the ventricle typically and then going up into the atrium. That's the only reason this signal should be predominantly upwards. But rarely you can see this sort of extreme axis deviation, which is definitely conducted through the AV node because there is very clear relationship with P waves and the QRSs. And here can you see that the signal is between AVR and AVL, and so the signal is pointing somewhere around here at slightly under minus 90 degrees. So that's a very, very profoundly negative QRS axis. And in fact, if it's negative in 2 and 3, or predominantly negative in 2, that shows that it's swung round past AVL and is negative. If, on the other hand, it's negative in lead 1, that's because the axis has swung round and is pointing predominantly away from lead 1. And that would be right axis deviation. And so the simple way you can work it out precisely using this sort of a diagram, and there's more subtlety to it than I've gone into today, or you can simply look at leads 1, 2 and 3. And normal axis is if it's positive in 1 and 3. Right axis deviation is rarer than left axis deviation, and that's if it's negative in 1 and positive in 3. And left axis deviation is if it's negative in 2 and 3. So we'll move on and look at the potential relevance of that in a moment. But this ECG combining right bundle branch block with left axis deviation, this tells us it's not just that there's right bundle branch block, there's also block of part of the left bundle, and in this case it's a left anterior fascicular block, and this together is called bifascicular block. What about this ECG? So are these QRSs broad or are they narrow? If we look at our rhythm strip, can you see that they are narrow in appearance? But look at our chest leads. They're broad. They're 120 milliseconds, maybe 140 milliseconds, particularly if you look at V1 or V6. So are we broad or narrow? Which lead should we measure our QRS duration in? Well, the answer is in the one that makes it the longest. The QRS duration reflects ventricular depolarization, and that happens at the same time in each lead. It's just how that depolarization signal is reflected in the lead, how it's detected by that lead, and that depends on whether it's in the direction of the lead or if it's fairly isoelectric. And you can see that lead 2 is fairly small, complex, fairly isoelectric relative to the chest leads, and so it's not picking up the repolarization, the end of depolarization very well with this little bump here. It's also got small T waves, so it's not picking up repolarization very well either. So we measure it in the longest lead, and you can see that we've got a little r, big R, and an S wave in V6. So again, we have typical right bundle branch block. But more than just that, we also have first degree heart block. So this ECG shows bifascicular heart block, right bundle branch block, and first degree heart block. So what is all this that I'm talking about bifascicular block based on? Well, the electrical conduction system of the heart consists of the sinus node, which initiates, that's your natural pacemaker initiating contraction, and when the sinus node beats, it sends a signal through the atrium to the right and the left atrium telling them to contract, and then there should only be a connection to the ventricles through the AV node, and that starts off as the AV node, and then it becomes the bundle of His, and that has got left bundle and a right bundle. These are the Purkinje fibers, and the right bundle, the right ventricle, remember, is about 10% the muscle mass of the left ventricle. So the vast majority of the muscle mass of the heart is the left ventricle. So the right bundle only has a single fascicle to it because it's just simply not subtending as much muscle, whereas the left bundle has got two fascicles that we recognize, left posterior fascicle and the left anterior fascicle. So if we have first degree heart block, then we're presuming that that's a problem either in the AV node or in the His. And if we have fascicular block, that is block of these fascicles. So if we have left bundle branch block, we've got block of these two fascicles, so that would technically be bifascicular block. If we have right bundle branch block, that's one fascicle. So combine that with what we've just seen, which was a left anterior fascicular block, and we have two fascicles blocked, we have bifascicular block. Trifascicular block, you might say, well, that's block of all three fascicles, but of course that isn't really trifascicular block, that's complete heart block. And so we have, by habit of, and what's been handed down to us by posterity, we consider disease in the AV node or His to reflect on disease in the fascicles, so we treat that as a separate fascicle. And if you have either two of the fascicles blocked and then first degree heart block, then that's enough to call it trifascicular block. So I bet you can't guess what this ECG shows. Well, don't guess, have a look and tell me. So we've got another broad QRS here. Can you see it's a nice clear M shape in V1? Look how narrow it looks in V4, but again, go back to the rhythm strip. You can see that these are not ventricular ectopics. This is a consistent rhythm all the way through. This is just the way it happens to appear in V4. This is quite a low voltage ECG. So we have a little r, big R, typical right bundle branch block in V1. We haven't got an S wave look in V6, which is a bit unusual. So this is not completely typical right bundle branch block, but we're satisfied that there's a very clear relationship between A and V. So this is being conducted through the AV node. So we have right bundle branch block. We've got negative in 2 and 3, so that makes it left axis deviation, and the PR interval is on the long side. If we measure from the start of there, it's over 200 milliseconds. So this is trifascicular block. Now bifascicular block, or even right bundle branch block on its own, and certainly left bundle branch block, together with cardiac syncope by classic Stokes-Adam type falling over flat while walking and breaking your nose type syncope, that is enough to implant a pacemaker. On its own, it's without any symptoms, it could just be the way the patient's ECG has been for many years. I've seen patients with trifascicular block for over 10 years, and it's really can be challenging when you have patients with loss of consciousness that isn't typical cardiac syncope. So for example, the patient passes out for 15-20 minutes and is seen during the episode, and there are concerns that the GCS is low but they've got a cardiac output. They very often I get referred as, are they heart block, but they really don't sound like it at all, and they have always got an abnormal ECG for them to be referred to me. So do you put a pacemaker in or not? Well, the guidance would be that if you don't have typical cardiac syncope, you shouldn't be putting in a pacemaker because any procedure carries risk. So this is trifascicular block, and you would be thinking, even as an asymptomatic patient, about doing a heart monitor to investigate for high degrees of block. But in itself, without any symptoms, without any other high degrees of block seen, it doesn't require any further treatment. What about this ECG? So take a moment to have a look at it and interpret it for me. Can you see along the rhythm strip that we have regular broad QRS complexes and then an abnormal complex, then compensatory pause? Can you see that the gap between this and the following QRS is greater than it's been the RR interval or previous beats, and then on previous rhythm resumes? So this is a ventricular premature beat or a ventricular ectopic beat. My apologies that these lines are slightly wonky. Can you see the vertical on my screen doesn't quite line up with the verticals on the 12-lead ECG. So this ventricular ectopic has got an atypical right bundle branch block morphology. It's got predominantly R wave, but it doesn't have an RSR pattern. It's just got a big R in it. So this is clearly therefore coming from the ventricle. And we have P wave followed by QRS. P wave followed by QRS. And these intrinsic QRSs, so the patient's natural heart rhythm we talk about as their intrinsic rhythm, these are broad, and it is negative in V1, and it's a V shape. And this is left bundle branch block. I'll come on to that in just a second. Can you see the P waves are seen quite clearly in V1, but they're not seen very well at all in lead 2, because lead 2 is very isoelectric. And can you see how the P waves are just hard to distinguish from the T wave? So very difficult to be certain about what's T wave, what's P wave if you look in lead 2. And if lead 2 doesn't show the P waves well, the natural place to go for it for them is V1 and V2. They tend to show P waves very well, particularly if lead 2 doesn't. Can you see that if we look at this P wave and follow it down, because obviously it occurs simultaneously across all these leads, can you see how actually here you can see the P wave reasonably clearly in lead 2? And that's because our ventricular premature beat has been followed by a compensatory pause, so you don't have the T wave confusing what's P wave and what isn't. And now that I've shown you that, you can see that actually they are quite separate, and there's a P wave following the T wave. So that can help you to interpret it by looking at it across the different leads, or you could just ask for V1 to be given to you as the rhythm strip. So this is left bundle branch block, and we tend to remember left bundle branch block with the word William. I don't really see a W in lead V1. I can see a V very clearly, but I can't see a W. The reason we say W is because often there is fractionation of that V, and so it starts to become look a little bit like a W, and I'll show you an example of that later on. But I tend to prefer using the word Victor. Here you could call that an M. More often than not it's more like an A. But this is, I think we can all agree, definitely an R wave. So we expect a V in V1 and an R wave in V6. And Victor, I think, is quite a good way of remembering left bundle branch block, but really whatever works for you. So this is left bundle branch block and first degree heart block. That is trifascicular block, because remember the left bundle has 2 fascicles and the first degree tells us there's disease in the 3rd fascicle, or so the saying goes. So again, trifascicular block managed very much as the previous patient. This ECG is quite an interesting one. My apologies for the poor quality of it. It's a rare ECG and I haven't got a better example. So what on earth is going on here? Is this left bundle branch block or is it right bundle branch block? Well, this is the kind of ECG that really confuses people, and if you don't like it, just move on. But because it's rare and you want to really do cardiology to need to be able to interpret it. But it is predominantly R wave and V1, so it is right bundle branch block. And in fact, can you see there's an RSR pattern in V1? So this is right bundle branch block. But look into V2 and you've got your W, this fractionation we talked about. It's not only a V shape, it's also got fractionation. This is very early transition from positive to negative. And this is obviously a typical appearance of left bundle branch block, which is where the confusion comes in. And it looks like left bundle branch block really from there on, although here we've got S wave rather than R wave. So not really making sense at all. And look over here. Can you see that this is right axis deviation? So what in fact this is we have trifascicular heart block with first degree heart block, right bundle branch block and left posterior fascicular block. So remember there are 2 fascicles and the common one to be blocked is the anterior one, which causes left axis deviation. But here we have marked right axis deviation. Look, it's even positive in AVR. So this is the posterior fascicle being blocked together with right bundle branch block. So another example of trifascicular heart block. So next up we have one of the ECGs that I think causes the most confusion. And this causes a lot of confusion with complete heart block. We have a narrowish QRS duration, so within normal limits, and we have clear-cut P waves, but we have lots of pauses. And we have more P waves than we have QRSs. And marking them out can be really helpful. So we mark out our P waves, which are occurring regularly throughout the rhythm, which they should do. P waves should be regular unless there are atrial ectopics happening. And then we mark out our QRSs. And can you see that the QRSs are not occurring regularly? And if it were complete heart block, the QRSs should occur regularly unless ventricular ectopics are confusing the situation. So then, having marked them out, can you see how the PR interval is gradually prolonging? And then we get block and we lose a QRS. And then the PR interval resets and gradually prolongs again before again it misses. So this is Ventricular heart block, or Mobitz type 1 atrioventricular block. And this is a normal finding in a young patient overnight. Often athletes with high vagal tone can get some Ventricular, and it's not a problem if when they exercise the Ventricular disappears. But if you have an elderly patient who is having this sort of ECG at rest during the day when they shouldn't have high vagal tone, they shouldn't have a reason for it, then it is suggestive that they've got disease of their conduction system and they are going to need a pacemaker. So it depends really where you see this. If this were a bit of 24-hour ECG for a young person overnight, I wouldn't think twice about it. But for an elderly patient, as a routine ECG done for pre-surgical procedure or for whatever other reason, not done for anything specific, I would be concerned that we need to look further to see if there are higher degrees of heart block that require a pacemaker. So in itself it doesn't need it, but it should raise your suspicion depending upon the circumstances. So now we have another ECG, and I'll give you a second to look at that before I tell you what it shows. Feel free to pause if you need longer. So I'll start off by talking about the QRSs. Can you see that this appearance is a little bit atypical, but there is perhaps a tiny R wave followed by an S wave followed by a larger R wave, so our RSR pattern. And we've got a small S wave in V6, so this is right bundle branch block with a broad QRS. And can we see our P waves nice and clearly? So we have two P waves to each QRS. So this is 2-to-1 heart block, or Mobitz type 2 AV block, and right bundle branch block with a normal axis. So this is an absolute indication for a pacemaker, even if it only occurs briefly, unless there's a reversible cause. So sometimes elderly patients get, or young patients get put on combination of bisoprolol and diltiazem to control their angina or their fast AF, or they have bisoprolol and digoxin, and then as they get older their rate control ends up being easier, or for their angina they get a more diseased and elderly AV node that doesn't need as much strong medication to slow the heart down, and then they develop heart block. So maybe 10 years passes without a review of their medications, and in that time they start to develop a problem. So look out for that kind of a treatment. If they are on timolol eye drops is the classic question in exams. That can do this, but it would make me very wary of if such a tiny bit of beta blocker was causing 2-to-1 heart block. It suggests to me that they're going to need a pacemaker, and I'd much rather put it in now than wait until they have a crash in their car or they fall and break their hip because they've blacked out suddenly. So if you've got a very good reason for this to develop, you can avoid pacing, but even an incidental finding in a completely asymptomatic patient, this needs a pacemaker. If I saw a little bit of this on a 24-hour ECG, I might arrange an urgent outpatient pacemaker. If you've got a highly symptomatic patient or you found it on a resting ECG, I'd be thinking about an admission, because I'd be worried about higher degrees of block happening. So very important to spot this and to offer a pacemaker. The other thing to think about is thyroid function. Sometimes this can be a sign of profound hypothyroidism. What about this ECG? What's the heart rate here? Well, it's nicely marked for you up here on the ECG at 35 beats per minute. How could you work that out? Well, you can divide the 300 by the number of large squares between complexes, or quickly on an ECG with few complexes like this, you can count the number of complexes, which is 6, multiply by 6 because this is a 10 seconds of recording, and get 36, which is basically the heart rate which the computer has calculated. And as soon as the heart rate goes below 40 and even below 45, you should really be looking for a form of heart block, because it's very unusual to have sinus rhythms with rates less than 40. But here, this is sinus bradycardia, and you can say that with confidence because if you look at the P waves, you can't see anything at all in the middle. So it's not 2-to-1 heart block, and there is a consistent PR interval. So this is simply sinus bradycardia. And this sort of patient, maybe they're on too much medication to slow them down, and like the patient we've just described, it hasn't caused heart block, but they need to have their medications reduced. Maybe they have got hypothyroidism. Maybe they're an athlete and they've got a tendency to very slow heart rate at rest because their heart's used to working so hard at exercise. It has adapted and doesn't need to pump so hard at rest. It's also possible that an elderly patient has got chronotropic incompetence and sinus node disease and needs a pacemaker to speed them up. In the absence of symptoms, maybe they don't need a pacemaker, but I sometimes see patients that don't realize just how bad things have got. They've just put it down to aging, and they get a new lease of life when you offer them a pacemaker. We could get them to exercise and see if their heart rate speeded up appropriately. Just getting them to do exercise while they've got a 24-hour tape on or a formal exercise test is an option. We have to be wary about putting in pacemakers to asymptomatic patients just because they have slow heart rhythm. But if it is truly remaining this low in an elderly patient, I would be concerned about it. I would be much less concerned in a young athlete. So just sinus bradycardia. What about this ECG? So look at the P waves. In fact, I'm marking the QRSs first. Look at the QRSs, and they're regular. And look at the P waves and map them out along the ECG. And can you see that the P waves don't line up, don't have any relationship with the QRSs? There's unphysiologically short PR intervals in some places, and there's P waves forming parts of the T wave in other places. So no relationship. This AV dissociation tells us this is complete heart block. Now, you can have a narrow complex escape rhythm with complete heart block, as there is here, and that's a sign that they're hopefully relatively low risk, but it doesn't change the fact this patient needs an immediate hospital admission from wherever they are and a monitored bed, because they are at risk of asystole, or they can go into VT-VF, and they can do that without any warning. So this patient needs immediate monitored bed and immediate hospital admission, irrespective of the cause, unless their quality of life is such that we shouldn't be doing anything further for them. The presence of syncope, or if the patient has acute renal failure or is not passing urine, would be reasons to put an emergency pacemaker. If they're if they're fairly asymptomatic, maybe just a bit of fatigue, then I might not rush to do it in the middle of the night, because procedures do carry more risk in the night, but I'd be having a very low threshold to put in an immediate pacemaker here. Can you see, this is quite a nice example of how you can map out P waves once you've got two. So see, there are two nice clear ones here together, but here you might not be sure that was a P wave until you notice it's halfway between these two, and you're expecting one halfway between these two. Here, can you see there's a P wave falling on top of the QRS that you can recognize as being a P wave now that you know to expect it. Over here, this T wave has got a P wave on its back, and so it's broader than the P wave when it's in isolation. And here this T wave has got a P wave standing on its head. So you can see that the P waves, even when they're merging with the ventricular signal, if you can map them out like this. And so you can very clearly see this is complete heart block. What about this ECG? So QRS duration is more than 120 milliseconds. Can you see in V3 we're getting a little bit of fractionation of it, which is our W that we talk about with our left bundle branch block. We've even got almost an M in V5. So this is left bundle branch block. The rate, we have 6 QRS complexes, rate of about 36. What's the atrial activity? Can you see that it is a pretty flat, but this is fairly fine atrial fibrillation. We can't see any P waves. So is this slow AF or is this complete heart block? Remember, the rate's less than 45, certainly less than 40. We should really be thinking hard, is this complete heart block? How can we tell? Well, if the signal is coming from the atrium and there is contract between the atrium and the ventricle, then it should always be in a regular rhythm. It should always be in a irregular rhythm. And here it is a very regular rhythm if you account for the fact my ECG is slightly wonky. So it's far too regular for this to be atrial fibrillation. This is complete heart block. And so this needs to be treated exactly as the previous ECG, and it's one not to miss, because if you just say, atrial fibrillation, slow AF, I'll reduce their beta blocker, maybe all will go well, but there is a risk that that patient has an arrest in the meantime because of their complete heart block. So this kind of patient needs to be treated exactly as the other one. Look out for this. Regular rhythm in atrial fibrillation means AV dissociation and means think complete heart block. Even in our patient who is very frail and maybe even bedbound, we need to think hard about this, because sometimes complete heart block's missed and it can cause a frail elderly patient to become bedbound. And maybe we just need to put a pacemaker in and their cognition will improve because they're getting better cerebral perfusion and their mobility and quality of life can be transformed. So think very carefully before saying somebody isn't a candidate for a pacemaker. But obviously the last thing you want to do with somebody who has long-standing very poor quality of life is to put a pacemaker in when it doesn't help the situation. The problem is knowing for sure that it won't. So that needs an expert assessment. So that was complete heart block and atrial fibrillation. Well, thank you very much for watching. There's plenty more teaching on ECGs available on my YouTube channel, and I hope, as a parting note, that if any of you are really cool and have amazing tattoos, that you have electrically accurate tattoos. Thanks a lot for listening.